forward, backward, and this is the laser pointer.
Well, thank you. Thank you, Binay, for the introduction, the invitation to speak at this meeting about acute leukemias. So this is unlike many other years. There's a lot of ground to cover. A lot of things have happened. And in the last 1 or 2 years, that's particularly true for AML, not so much for ALL. So we'll mostly focus on AML, but thought I would just start briefly to remind everybody in the room what has happened over the last maybe 5 or 10 years in ALL, and then sort of contrasting this with AML. There's several fronts where advancements have been made in the last 5 or 10 years. One is just like in many other heme malignancies, a lot of focus on genetic testing in ALL, maybe particularly to recognize this new entity of that's called Philadelphia-like ALL, a disease that by gene expression profile looks like Philadelphia chromosome ALL, but does not have the canonical Philadelphia chromosome. And it's important to recognize it because it has a poor outcome to chemotherapy, and some of the mutations that are common in this entity are now targetable with new agents, and this is actively pursued as a treatment avenue. There are several new drugs approved, and I'll show those in the next slide. And they're all approved for the treatment of relapsed refractory disease, but there's current efforts ongoing to bring these drugs to the upfront setting, although they're not approved for that indication yet. Following up on the data that younger adults seemingly do better when they get pediatric treatments, there's increasing interest in treating at least the younger section of the adults with these pediatric-inspired therapies. And ALL is really sort of the paradigm disease where MRD-directed therapy is up and running for a number of years, with at least some randomized studies making an argument for that strategy. There's 5 drugs approved, and when you look at this with a bispecific antibody and antibody-drug conjugate and CAR T cells, it's really in the forefront of this new wave of immunotherapies. Now, when you look at the indications, even though they're all approved for relapsed refractory disease, the exact indications differ quite substantially between the individual drugs, as do the side effects. And some of the side effects are quite unique to the drug that is used. And that certainly factors in now when we're having to make decisions on how to treat any given patient. So things like what is the exact disease situation, what's the disease burden? Some drugs seem to work better with high disease burden than others, whether it's a transplant immediately in the future or not, but also costs and treatment logistics really factor in. And this has become quite complicated, and it's certainly a situation where it's worth talking with an ALL specialist when you treat the patient in a more community setting. But sort of shifting gears to AML, many of the fields are similar to what was happening in ALL. There's a lot of emphasis on molecular profiling. I think AML is now well enough studied that all the mutations that will occur with a reasonable frequency have been identified. And it's now becoming more and more important, not just for prognostic reasons, but also for therapeutic decision-making, to have a good sense of what the molecular profile is of any given patient. With adjuvant arsenic, we've been able to turn the most deadly form of acute leukemia to the most curable form without use of any chemotherapy, at least in the low-risk patients. And I spend most of the time afterwards going over the new drugs that are available to us. But just to say, AML is also a disease where MRD plays an increasingly important role, although we're not quite as far advanced in knowing what to do with it or how we should use it as the ALL field is. And maybe sort of a little separate, but something that we, at least in Seattle, pay more and more attention to. There's this, a few years ago, AML was sort of thought, well, it just happens out of the blue, but there's sort of more and more recognition that a good proportion of patients have a strong family history of cancer, and there's certainly AML predisposition genes that are not uncommon, and for younger patients, something to consider, perhaps particularly when you think about transplant and which donor you might want to pick for any given patient. So I think we're at sort of a break point in time in that we're doing more and more molecular profiling of patients up front, and now particularly because we have an increasing number of drugs available that we can use to target some of these molecular mutations. It's still used for risk stratification, and every rendition that comes out of a risk scheme is going to look more and more complicated. the one on the slide is not really meant for you to read, but just sort of highlights how complicated it's gotten with an increasing number of mutations sort of factored in. And it doesn't need a genius to say that the next version that's going to come out is going to look even more complicated than this, with our recognition of what the prognostic significance are of individual mutations that we commonly find in AML. But the one thing that I wanted to highlight here is, even though we sort of know or seem to know what some of these mutations mean prognostically, these schemes don't really address the fact that these mutations don't come in as a vacuum, they come in the context of other stuff. And at least for some of these scenarios, it's now well recognized that it matters in which other stuff a mutation arises. And this is an example I took from a paper that was published a few years ago in the New England Journal, sort of highlighting this, that at least for some of the mutations, it really matters in what context they arise. So this is an example where probably a relatively common one, we have a patient with or without an NPM1 mutation, DNMT3A mutation, something we commonly check in these days. And when you just pay attention to the green and the purple curve, this is looking at the prognostic significance of FLT3-mutated abnormalities, something that we commonly think of, well, that's something bad. But it really, how bad it really seems to depend quite heavily on what the context is and what the NPM1 and the DNMT3A mutation status is. Now, this is just one example. There's several more that are published, and I'm sure there's many that we don't really know of, but something to keep in mind when we look at these prognostic schemes where really the mutations are sort of there as the individual mutations. I think really the exciting part in AML is the availability of now 8 new drugs that got approved in the last 2 years. And what I wanted to do for most of the rest of the talk is go over these drugs and sort of highlight where they're used, but also what the level of evidence was with which they got approved. And as you will see, that is really quite strikingly different. I mean, I think it's important when we make our treatment decisions for or against the use of these drugs. And unlike ALL, the drugs here have been approved not just for the relapsed refractory setting, but also for the upfront setting, and not just for fit people, but also for what's quote unquote the medically less fit or unfit individuals. And some of these drugs have really started to influence how we use or how we think about induction chemotherapy for fit adults. And as you know, the 7-3 regimen has been around since the early 1970s. And despite all these new drugs, it's still a level 1 recommendation by the NCCN to use it. There's been a number of attempts to kind of make small changes to that backbone, and by and large, those have not been super successful, perhaps with the exception of using high dose of daunorubicin, although that may perhaps only help for people with FLT3-mutated abnormalities. There's at least some European data that cladribine addition might make a difference for higher risk patients, but I don't think that study has made a lot of impact in the US anyways. But then the 2 drugs that really have started changing how we give induction chemotherapy, and I think we've seen this at the end of the lymphoma session by David, is the 2 drugs that got approved as add-ons for 7+3 chemotherapy, Midostaurin and gemtuzumab ozogamicin or GO. And there's one drug that is not meant as an addition, but as a substitute for 7 and 3. Now, the first drug I want to talk about is Midostaurin. It's the first generation tyrosine kinase inhibitor that is really a broad tyrase kinase inhibitor and by no means a FLT3 specific inhibitor. And this drug got approved based on the RATIFY trial, which was really a sort of a huge effort internationally where like several thousands of people got screened and ultimately over 700 enrolled. And randomized between standard induction chemotherapy plus minus midostaurin. And what the data shows is that addition of midostaurin changes the overall survival significantly. But when you look at the curves, you'll see this is not a game-changing drug. I mean, it's really, and just like most of the other drugs they're going to show, or all of the other drugs they're going to show, these are incremental benefits over what the standard of therapy is. The drug has been, in this trial, has been only given to FLT3 mutated patients, although some of the data makes people wonder whether the benefit truly is limited to people with FLT3 mutations. But within those, the benefit seems to be about the same whether you have a high allelic ratio of FLT3 ITD, a low allelic ratio of FLT3 ITD, or a TKD abnormality. What is interesting to note when you look at how the drug's labeled in the US is this trial was done for adults up to the age of 60. And the drug's approved regardless of age. And that is, I think, in some ways good because it gives us more flexibility, but it also raises the question whether the benefit that's been seen here really can be easily extrapolated to other patient subsets. And just to sort of highlight this issue, for sorafenib, a drug that is perhaps a bit more difficult to tolerate than midostaurin, but is also a first-generation tyrosine kinase inhibitor, there's randomized data showing a benefit in younger adults, but in older adults there isn't because the toxicities outweigh or at least level out the disease control benefit that the drug has. So something to keep in mind when you think about using midostaurin. But because FLT3 is such a common abnormality in AML, there's always a huge interest in coming up with newer drugs. And so there's at least a second-generation tyrosine kinase inhibitors are in the clinic, in clinical testing. And compared to the first generation, these are now have sort of a more narrow spectrum of how they work, but they're much more potent against FLT3 abnormalities. And the first drug that got approved a bunch of months ago was Gilteritinib. And the trial that was used to approve it is a trial that was done in the relapsed refractory setting where people were randomized in a 2-to-1 fashion between single agent Gilteritinib and sort of a standard chemotherapy backbone of choice. And what the data has shown is that the CR rates are higher and the survival is longer with the use of single agent tyrosine kinase inhibitor compared to the chemotherapy. But again, like when you look at the curve, you know, it's like this is sort of the advantage of these statistical tests. Oops, sorry, wrong button. You know, they sort of overemphasize changes at the beginning of the curve, right? It's not that you're curing more people, they just relapse later, that the actual plateau is at the exact same point. So again, this is an incremental benefit that we have, but it's not a game-changing outcome difference for people with relapsed refractory FLT3 ITD or other mutations. Now, there's other trials ongoing with this drug, and it's possible that ultimately the approval will be extended for upfront studies or for upfront use. There's upfront trials ongoing. And there's several other FLT3 inhibitors in the testing that may add to the approved drugs. You may have heard that Quizartinib was up for approval consideration, at least with the data provided at that time, it was rejected. Even though when you put the curves next to each other, they look fairly similar. So it's not a fundamental difference in how this drug works versus the other. But there's more trials with Quizartinib ongoing with other tyrosine kinase inhibitors, and likely we're going to see more drugs being approved with similar data like this. Now, to the second drug that was approved for the use with 7 and 3 chemotherapies is gemtuzumab ozogamicin. We heard a little bit already at the end of the lymphoma session about it. Now, the approval for GO, which obviously has a long story, is very broad. It is approved not just for the use together with chemotherapy in the upfront setting, but also as a single agent upfront for the less fit individuals, and it's approved as a single agent for relapsed refractory patients. And just to sort of highlight the level of evidence behind these indications, the upfront use in combination is really strongly supported by several large randomized studies. The single agent use is a single randomized study that compared the drug against best supportive care and found an advantage of like 1.5 months in survival. And I've not seen a person using this drug in this setting so far. But then for the relapsed refractory setting, where I think we at least consider using the drug, there really isn't a single randomized study that has shown a convincing benefit in the use of the drug, because there really haven't been any randomized studies in this setting. But the use is really well supported in the upfront setting together with 7 and 3 chemotherapy. And you've seen these curves before. The 5 studies that have been done were all different in chemotherapy backbones used, exact patients treated, how GO was given and what dose was used, and what benefit was observed. So really what kind of helped sort out what might be the benefit is this meta-analysis, that showed that GO really does not impact early outcomes. It doesn't change CR rates. It doesn't seem to, and it's questionable whether it changes the MRD rates with remissions. But it does reduce the relapse risks, and it does prolong survival when added to induction chemotherapy. When the overall survival data were broken down by cytogenetic risk, it was really noted that the most striking benefit was in the favorable risk patients, where the difference was like 20% difference in 6 years. There was a little bit of a benefit in the immediate risk, but there really wasn't a benefit, although also no negative, in the adverse risk patients. And this certainly has led to many people advocating for its use primarily in patients with favorable and perhaps some patients with intermediate risk disease and not those with adverse risk disease. But even though there's several thousands of patients that have contributed to what we know about GO in this setting, there's still a lot of open questions. And some of them I've highlighted or put on this slide. Like one is, for example, what is the correct dose? In the meta-analysis, it appeared, so the trials have used either 3 milligrams or 6 milligrams per meter square as a single dose. And what the meta-analysis suggested is that the 6 milligram dose was simply more toxic than the 3 milligram dose, but really didn't provide any more anti-leukemia benefit. And that was subsequently confirmed in a randomized study that the United Kingdom AML group has performed, basically showing the exact same this conclusion. But just to sort of highlight, this was a trial that was presented at last year's ASH meeting. So people think, well, 3 milligrams is probably safe to use. But this German randomized study has used the 3 milligram dose. And in that experience, it was a multi-center randomized study, the drug had increased toxicity and sort of negating the benefit that was observed with regard to relapse risk reduction. So even though 3 milligrams seems reasonably safe, based on a number of studies, it's not entirely harmless to use, and you still have to sort of pay attention to toxicities that can arise. The second question is, well, so if you settle on the 3 milligram per meter square dose, well, what is your optimal dosing regimen? In the randomized studies, there's been two ways of doing it. You either give a single dose, or the French group has given 3 doses of the 3 milligram per meter square dose. And when you look at the randomized and the meta-analysis, it appears like this fractionated use looks better. And I think that has led to the FDA to kind of put that regimen on the label. And I think when we get calls about what you should use, we often say, well, use the French regimen to use. But the question then comes up, well, how safe is it truly? And in the French experience, there were very few patients transplanted, but they observed a few patients with SOS or VOD. So I think that's something that we will have to pay attention to in the next years, is how big of a problem is SOS and VOD truly when we start transplanting these people more regularly. And anecdotally, we certainly have had a patient or two that had SOS or VOD and had these sort of lower dose of Mylotarg in our institution. I think a clinically really relevant question is, what should you do with a patient that has maybe an intermediate risk leukemia, but also has a FLT3 ITD abnormality? Now you have GO to use, and you have a tyrosine kinase inhibitor to use. They both have benefits. There's no data to say that GO doesn't work. In fact, some data say they work particularly well for FLT3-mutated patients. And the magnitude of benefit is about the same. So what do? You pick one, you pick the other, you pick both. I think we've seen it now that people start combining these drugs, and I think that sort of is intuitive. But there really is no data at this point to argue that this adds benefit over the use of just one of the drugs or just adds more toxicity to it. There's some trials ongoing to address this question, but there's not going to be any data in the near future on this. And then I think one that has raised sort of waves is whether you can use genetic testing for patient selection. There's a large pediatrics trial that has shown that a particular single nucleotide polymorphism in the CD33 gene is associated with benefit to GO in this large pediatric trial. And it's now been sort of advertised that you should test your patients for this abnormality. I think in the adult world, it's a little less clear what the benefit truly is. The United Kingdom group that has treated a large number of people with GO in a randomized fashion has not been able to confirm that this association held up in their study. So I think it's still an open question whether you can easily extrapolate the pediatric data to the adult setting here. Now, another drug that got approved in the upfront setting is CPX-351, which is really sort of a fancy packaging of 7 and 3 chemotherapy within liposomes. And the idea here is that the liposomes provide a more prolonged exposure to the drugs in a particular ratio that, at least in vitro, you can show is particularly efficacious in killing leukemia cells. To the credit of the company that had CPX at the time it came into the clinical testing, they've been very quick in doing small randomized studies to kind of get a sense where the benefit might be. And one of the early studies overall testing CPX against 7 and 3 in sort of medically fit people with AML was overall there was no benefit of using the drug, but in subset analysis it appeared that the secondary leukemia patients had a benefit with this drug. So the company followed up on this sort of early potential signal and construed a phase 3 randomized trial focusing on this particular patient population, older adults 60 to 75 that had a form of secondary AML, either arise from MDS, from CMML, or had AML with MDS karyotype abnormalities, and randomized them between 7 and 3 and CPX-351. And what the data showed is that CPX led to higher response rates and lower early mortality rates. And the lower mortality rates were primarily attributed to fewer deaths from early progressive leukemia. And again, when you look at the survival curves, you see a shift towards up, so the drug does provide a benefit. But again, it's sort of an incremental benefit over the 7 and 3 therapy. What's interesting in the data is that when it was broken down to the patients, to the somewhat rare patients that got a transplant afterwards, the post-transplant outcomes were strikingly better for people that got CPX beforehand, which sort of led to a lot of speculation whether this was because CPX is particularly efficacious in getting good remissions. And that's something that unfortunately can't be easily tested because MRD was not assessed in this trial. But somewhat opposite to what the Midostaurin approval was, again, I told you Midostaurin was tested in younger people, it's approved for everybody. CPX is now tested in older adults, but it's approved throughout all the ages. And again, at this point, without much data to support that what you might observe in a younger person is similar to what you might see in an older person. So those are the drugs that are primarily used in the upfront setting. I think a lot of effort in the drug development world has been paid to the development of drugs for the quote-unquote medically unfit adults with AML, for which, even though there sort of is a standard, the standard is really not good. And I would say in the US, it's probably primarily azacitidine or decitabine that's been used as a standard so far. Now, there's 2 new drugs that were approved specifically for this setting. I'm going to talk about these in the next slides, Venetoclax and Glasdegib. But also with these other molecularly targeted drugs available, there's now more interest in sort of profiling your patients and choosing doublets or perhaps triplets based on your mutational profile. But the 2 drugs that got approved, one of them is Venetoclax. We heard about it in the lymphoma group or in the lymphoma session about the use of Venetoclax in the lymphoid malignancies. The beginning of Venetoclax in AML was rather modest. There was a single drug study in relapsed refractory AML, and the response rates were quite low. They were like 5% CR rate. So it was a modest beginning. But what people are really excited about, and that's the basis for the drug approval currently, is the upfront use together with either low-dose cytarabine or one of the azanucleosides, decitabine or azacitidine. And what these 2 drugs so there's been 2 trials, both 1B, 2 trials that have tested Venetoclax either combined with low-dose cytarabine or with azacitidine and decitabine. And I sort of put some of the outcomes on the slide. And really what the buzz is all about is that in these combinations, you seem to get really remarkable response rates, CR and CRI rates. And that when you, I'm not sure this is big enough on the slide, but when you look at some of the subsets, they seem to extend over a larger subset of patients. At least for one of the trials, it's been shown that it's sort of the higher response rates extends over the cytogenetic risk spectrum. Even for TP53 mutations, you get a decent response rate here. And some of the remissions seem quite durable. Now, I think the one thing I would highlight here is that this drug, it's actually the only drug that got approved on a conditional level, is really approved based on on these single-arm studies. And there's not a single randomized study out there that really puts this in perspective, how much different this is compared to just one drug or what your standard drug is. And I think this is what we really need to get a sense of how valuable this combination really is. The drug seems to be reasonably safe to use, although cytopenias are a problem. And having talked to some of my colleagues at MD Anderson, where this drug has been used very, very widely, they are really concerned about the cytopenias to the point that when they use it in upfront combinations, they do bone marrows around day 21. And if the marrows are plastic at the time, they stop giving the drug to let the counts recover instead of just giving the drug continuously, just because of the ratio of cytopenias that might otherwise occur. The second drug that's approved in the unfit patients is this drug called Glasdegib, which is an inhibitor of the hedgehog pathway that's been implicated in cell resistance of AML cells to chemotherapy. Now, this drug got approved based on a randomized study in combination with low-dose cytarabine versus low-dose cytarabine alone. And what the trial has shown is, again, there's some incremental benefit of using the combination. I think the caveat here is that not many people use low-dose cytarabine anymore, and there's at least some data saying that this is actually worse than using azacitidine. So I think what we're really missing is any kind of indication that this drug adds to what you might get with azacitidine or now with another combination. So I'm not sure this drug is widely used in the clinic at this point, and maybe that's one of the reasons. So the last class that I want to just briefly go over are the inhibitors for the mutant forms of IDH. I think this is sort of biochemically very interesting concept in that IDH mutations are occurring in a number of cancers. In AML, they occur in IDH1 and IDH2, both in the frequency of about 5 or 10%. And what happens is with these mutations, there's an oncometabolite generated that leads to an epigenetic change of the leukemia cells, and with this, an impaired cellular differentiation. And these inhibitors that are tested are really specific for the mutated form of IDH and are able to overcome this cellular differentiation block that the mutation has. And the two drugs that got approved are lvosidenib, which targets IDH1, and enasidenib, which targets IDH2. And both of these drugs got approved based on a really large phase 1 trials, single agent phase 1 trials in relapsed refractory patients. And when you put the data next to each other, they're remarkably similar, right? The response rates are somewhere in the range of 20 to 30%. Some of the remissions are quite durable, in the range of 8 to 10 months. And the toxicity profile is very similar. It causes differentiation syndrome that in many ways looks similar to APL differentiation syndrome in about 10% of patients. And both drugs got initially approved in the relapsed refractory setting, but lvosidenib now is just a few weeks ago got approved in the frontline setting as well. And this is really remarkable in a sense in that it was approved based on a not published phase 1 study that included 34 patients. So we're talking about a very limited level of evidence supporting its use. But there's a lot of interest in testing combination therapies, both with intensive and non-intensive therapy, and I'm sure we're going to learn more about these drugs in the next few years. So I sort of gave you some of my thoughts as I went through the slides. At least several of the drugs were approved based on uncontrolled early phase trials. If they were tested in a controlled fashion, the benefit seems somewhat incremental, though there is benefit there. But even when the controlled trials I think, especially in a time where the standards change so quickly, you really have to look at what was used as the control arm, and is this really a legitimate control arm for your patient who walks into the clinic right now? And the one thing I would like to point out here is that the patients were really tested in sort of highly selected populations. And I think that is particularly true for the drugs that advertise to be used for unfit individuals. Like we were participating in these Venetoclax trials, for example, and they were geared towards the unfit patients. But some of the inclusion criteria really selected out quite fit individuals with good ECOG performance statuses and good organ function parameters otherwise. So I think it's going to be interesting to see in the next months and years what happens if the community starts treating the truly unfit people with these combinations, and whether these data then look as good as the trial data do at this point. So with this, I'll finish off. I think it's exciting, even though I was skeptical in some ways. There's exciting times in AML and ALL. We have a lot of new drugs to play with. For some of them, I hope I conveyed that. For some of them, we really don't quite know yet what the true value is, but we have them available, and we have a chance to figure this out. We've made a lot of progress in curing a form of AML without chemotherapy. And we know a lot about the genetic complexities of the diseases, which have given us real choices in new drugs, but also for the drug developers to come up with new drug classes to test. But sort of, I know that the speaker after me is a transplanter, just sort of the plug for the transplant, right? I've showed you all the data, and I sort of highlighted these are mostly incremental benefits. Even though we've made benefits or we've achieved some benefits, I think allogeneic transplant is as important as ever for the people with AML. And it's not going to go away anytime soon, I don't think. And with this, I'll stop. And